Good evening, everyone, and welcome to this Prostate Cancer UK webinar, Living with Incontinence After Prostate Cancer Treatment. I'm Nick Ridgman, and I'm the Head of Support Services at Prostate Cancer UK. During this webinar, we will give an overview of living with incontinence that's come about as a side effect of prostate cancer treatment. If you've been diagnosed with prostate cancer and are considering your treatment options, if you're waiting for treatment, or if you're already experiencing incontinence as a result of treatment, our information and tips will help you navigate your situation. I'm delighted to be joined by a wonderful panel encompassing expertise and lived experience. I'll let them introduce themselves very briefly, starting with Heather.
Hi, and welcome everyone. My name is Heather, and I'm one of the specialist nurses working for Prostate Cancer UK.
And Mike.
Hello, my name is Mike Ridley-Smith, and 11 years ago I was diagnosed with prostate cancer, and I'm also a volunteer for Prostate UK.
And Gerard.
Hi, a big welcome to everyone. My name is Gerard Green. I'm a male pelvic health physiotherapist with an interest in prostate cancer rehab, and I'm based in Birmingham and also in London.
Thank you so much. Now, I just want to let you know how this evening will work. Firstly, just to say we are here on a Zoom webinar. This isn't the same thing as a Zoom meeting, so everyone is only able to see and hear me and the panelists throughout the whole webinar. Your microphone and your camera are not connected to the webinar in any way, so you don't need to worry about that. First, we're going to hear from our panel. They'll explore a range of perspectives on incontinence, including how treatments lead to incontinence, what it's like living and coping with incontinence, and the various ways it can be managed. As we're going through, if you've got any questions for the panel, please use the Q&A function to submit them. I'm very glad that we have Grace and Vicky from the specialist nurse team here at Prostate Cancer UK on hand to respond to some of these in the chat. We will also have dedicated time for a Q&A discussion at the end, where we'll aim to get through some of these more detailed questions. We also had some submitted prior to this evening, so we'll try and cover some of those as well. Please don't include any personal health information in your question, otherwise we won't be able to answer it, and we can't give any health advice on individual cases. Please also note that only the questions that we answer will become visible in the Zoom chat. And we're really sorry if we don't get to your question this evening. If you're left with any urgent questions, remember the specialist nurse service is available Monday to Friday, 9 AM to 5 PM. A few final things. Please note that everything in this webinar is for general information purposes to help you understand and navigate your situation better. It does not constitute medical advice. And finally, we'll be covering issues around incontinence appropriately but candidly. If you find it difficult to listen at any point, you can of course step away. We'll circulate a recording of the webinar afterwards so you can catch up in your own time if you prefer. I'll hand over to Heather in a moment to get us started properly, but first we're just going to do a quick poll as we'd like to know a bit more about our audience today. So if you just bear with me, this first poll should flash up on your screen. So please can you just select any of these that apply to you, and don't worry, this is completely anonymous. So I'll just wait for some of those to come in. Fantastic, thank you all for answering. So yes, looking like the vast majority of you are in the position of you've got or you previously had prostate cancer, so lots of lived experience, which is fantastic. Some of you perhaps joining on behalf of a friend or relative who's on their own prostate cancer journey. Fantastic, thank you. That's just really good to get a flavour. So I'll just close the poll now. You should be able to close the window on your screen if it hasn't done that already. Right, I'm now going to pass over to Heather, who's going to give us a run through of incontinence and how it typically relates to prostate cancer treatment. Heather, over to you.
Thanks so much, Nick. That's brilliant. And I think based on what we know from the poll there, that it does explain that maybe a lot of you will know some of this information that I'm going to talk about now. So what is prostate cancer? We know that because of the topic we are discussing, that you are either, as I say, diagnosed with or close to someone with prostate cancer. Prostate cancer is one of the most common cancers in men. There are about 48,000 new cases of prostate cancer diagnosed per year in the UK and around 12,000 deaths. Treatment will depend on the location of the disease, whether it's within the body, within the prostate, just outside it, or in another area of the body. This is generally determined by MRI scans, biopsies, and additional scans such as bone or PET scans. Treatment will also depend on how aggressive the disease is or its Gleason score, as well as a man's comorbidity and personal choices. Prostate cancer has a vast variety of treatment options, but they can come with side effects, incontinence being one of these side effects. When we speak about incontinence, we generally refer to urinary incontinence, as this is the most common type of incontinence after prostate cancer treatment. On my slide, you'll see the stats that 1 in 2 men who have a radical prostatectomy will experience urinary incontinence. Trial data also varies on outcome, but it's reported that around 10% of men have reported experiencing some form of bowel incontinence as late as 6 years after radiotherapy treatment. We're going to move on to talk a little bit more about normal urinary function and what can go wrong when men have common prostate cancer treatments. So the urinary tract includes 2 sets of muscles that work together as a sphincter or a valve, closing off the urethra to keep urine in the bladder between your trips to the loo. The internal sphincter muscles of the bladder neck and the urethra stay closed until your brain send signals that tell you to pee. The external sphincter muscles around the internal sphincter sits around the internal sphincter and provides extra pressure to keep the urethra or wee pipe closed. You can consciously squeeze the external sphincter and the pelvic floor muscles to keep urine from leaking out. When you have to pee, your brain signals the sphincters or the valves to relax. Then it signals the muscles in your bladder wall to tighten, squeezing urine through the urethra or wee pipe and out of your bladder. Issues with normal urinary function may lead to some problems that are listed on my slide. Some of those are stress incontinence. This is when you leak urine as your bladder is put under extra pressure when you might cough or sneeze or laugh. Urge incontinence is where urine leaks out as you feel a sudden intense urge to pee or soon after. Overflow incontinence is when you're unable to fully empty your bladder, which causes frequent leaking. And then total incontinence is when the bladder cannot store any urine at all and causes you to pass urine constantly or have a frequent leakage. We're going to move on to talk a bit more about the common treatments in prostate cancer and how side effects like incontinence can be an issue. So on my slide, you'll see 3 treatments listed, and these are the most common treatments for prostate cancer. So to start with prostatectomy, we know that when the surgeon removes the prostate, they also remove some of the internal bladder neck sphincter that opens and closes to let urine out. This is the one I spoke about earlier that you need for urinary control. The muscles of the bladder and the urethra or the wee pipe can also be damaged during surgery. This in turn can lead to stress incontinence, where men notice a leakage when they cough or sneeze or make sudden movements. Fortunately, the outer sphincter is usually not affected and can be strengthened using targeted training, such as pelvic floor exercises, something that Jared is going to talk more about in a little bit. Men will have a catheter inserted after their surgery, and following the removal, they may notice that they have reduced urinary control. In the majority of cases, men will see improvements in their continence within early months, with many returning to full continent function. Most men will mention nighttime dryness as their first milestone. The next treatment is radiotherapy and brachytherapy. That's what I have listed here. So using radiation to treat prostate cancer can sometimes cause damage to the nerves and the muscles of the bladder, urethra, or the sphincter, which controls the passage of urine from the bladder. It can also reduce bladder capacity, and this can result in urinary incontinence, although this is much less common in radiotherapy than in surgery. In most cases with radiotherapy or brachytherapy, the symptoms are more likely to be radiation cystitis symptoms, meaning things like pain or frequency or urgency of urination. Radiotherapy can also affect the muscles that help keep stool inside the rectum. and this can cause problems with bowel control and leakage of stool. Finally, hormone therapy. So there's not a huge amount of evidence around hormone therapy, but some research has highlighted that men on long-term hormone therapy can experience weakened pelvic floor, and this can in turn affect their urinary function. So that's a quick overview of prostate cancer and incontinence. A lot of that you would probably know already, and maybe the next section where Jared speaks about the management is going to be of more kind of interest from a point of view of what to do next. I'm going to pass over now to our guest speaker, Mike. So Mike was diagnosed in 2013 when he was 55, after a friend went through his own diagnosis. An elevated PSA triggered a referral for further investigations, including a biopsy. And this found that treatment was needed, and Mike had a radical prostatectomy that year. He went on to have further hormone therapy and radiotherapy in 2014. Unfortunately, one of the side effects of Mike's prostate cancer treatment has been incontinence. I'm going to pass to Nick, who's going to chat to Mike about his experience.
Thank you so much, Heather, and welcome to Mike. Thanks, Heather, for introducing Mike and explaining a little bit about his story. And big thank you from me and on behalf of everyone else, Mike, for joining us to share your story today. Lived experience is so crucial to these webinars, and it really does make a difference. So thank you. Let me ask first, very simple question, but probably with quite a complicated answer. How has incontinence affected you? You know, think about emotionally, psychologically, socially, and physically. What's it been like for you?
Initially very difficult. After my radical prostatectomy, I was catheterized, which was a blessing because it meant I didn't have to get in and out of the chair to go to the loo. I found that for the first few months, I was using 5 or 6 pads a day. I also started to privately to go to Pilates on a one-to-one session, which I did find very valuable, particularly as the person who was taking me through Pilates had her own husband who'd gone through the same journey. So yeah, it was difficult. I think the whole stage when you early days recovery, you're in a bit of a tunnel and you just sort of try and get on with it and you handle it as best as you can, but it was very distressing to start with.
Yes, yeah, I can imagine, and I can hear how you kind of, yeah, you, as you say, being in a tunnel. I think, but for incontinence, for any side effect, and particularly around, you know, that diagnosis or that just treated phase, you often hear of people, yeah, really kind of becoming quite closed off and then going on a journey from there. I'm interested in what aspect, in what impact it might have had on you socially as well. You know, how did you find it kind of connecting with friends or doing activities that you might have done kind of pre-treatment? What was that like for you?
Well, by nature, I'm a very positive person, but because of the cancer diagnosis, I found that I just went downhill, and it was like a downward spiral mentally, which was not the Mike that myself or my family or friends knew. So my way of coping was to be as honest as I could with everybody, and everybody was incredibly understanding. I had lots of accidents, not just with my bladder, but also with my bowel. And pre-treatment, I didn't realize actually how bad this was likely to be. I sort of psychologically, because I thought the end was nigh and I was about to die within 2 or 3 years, the incontinence side didn't seem quite as important to me. I've now subsequently learned that actually, here I am 11 years later. I've been told that the chances of me dying from prostate cancer are far less than potentially being knocked down by my local bus, the number 33. So it's all a very positive outcome as regards prostate cancer. I also learned through prostate cancer, and who had a monthly meeting at somewhere called Maggie's. Some of you will have heard of Maggie's centres, and they were extremely helpful. But as part of the Maggie's experience, I actually learned that, aren't I lucky? Here I am, late 50s. I might be feeling a bit sorry for myself, but when you see people who are suffering from cancer, who might be in their teens, early 20s, and that was a very humbling experience. And I thought, well, actually, the incontinence side I can live with. I'm old enough to manage it. So that sort of gave me a knee-jerk, well, let's fight all of this.
Mm-hmm. Yeah, we often hear that kind of connecting in with that cancer community can provide you that solidarity and support, as well as giving a bit of context on your situation. So I'm not surprised to hear that was really useful for you. When you touched on, the Pilates as one way that you, in a very practical sense, try to manage some of this. What else did you do to kind of take control of your situation and to actively manage your situation around incontinence? I mean, not just practically, but I suppose just to medically, emotionally, psychologically. How did you take control?
I spoke to all the professionals, and again, I wasn't used to speaking to professionals about this sort of thing because I hadn't been poorly before properly. And one of the things I learned was there's a huge amount of help that's out there, and I can't not thank our local hospital trusts and my GP for helping me through the guidance and opening doors for me to get the help, and incontinence nurse specialists advising me, well, these are your options. It's not just about pads. They also talked to me about using a sheath arrangement, which I did use if I knew I was going to be out and I didn't know where there was a loo. I'd wear that just in case, and basically being prepared. I was very open, as I said before, with the family, but also with all my friends, and I think that's really important. So I could go out for a few beers with my mates, but they would know I'd be going backwards and forwards to the loo with no questions asked. So yeah, I think it's important just to be open and honest with people.
Yeah, absolutely. And it sounds like you really benefited from a very kind of open and warm kind of support network around you. How did you find it? I mean, how did you find it in terms of the wider environment and how kind of enabling that was? I think Heather will come on to touch on this later, but one of the things that's been a big part of our work at Prostate Cancer UK over the last couple of years has been around the Boys Need Bins campaign and making sure that there's provision in men's toilets for disposal and stuff like that. How did you find it kind of just being in the wide world and kind of using facilities, and was that stuff there for you, or was it a bit of a kind of frustration?
Well, it's actually interesting because I was asked, and I appeared on BBC Breakfast Time at the time where Durham Cricket Club had just started putting bins in the boys' loos, and that is so important because I tend to use a cubicle anyway, but you suddenly discover that you've got a soiled pad, you've popped it in, for want of a better word, a nappy bag. What do you do with it? So you come out and all of a sudden you've got like a nappy bag with you, and you're putting it into a bin where you're washing your hands, and people are eyeballing you thinking, what's he got? Is it a sort of secret that there's drugs, and then somebody else will come and pick it up from the thing. So I think it's incredibly important, and I love it when I now go round pubs and you know, arenas and things, and they've actually got a bin that you can dispose of the pads. I think it's incredibly important.
Yeah,
I
absolutely.
also, because I'm so open, I had a deal with my wife that if she could ever see me through my trousers, that actually she could see the pad outline. We had a secret sign, so she would just touch my leg. So I would nip off to the loo. And the other thing is, obviously, I was petrified that I could smell of wee. Thankfully, she never did, but I said, you must not hold back. I'm not, you know, please tell me. Because again, that's really important, because you think, ooh, you know, you don't want to have that old person smell.
Absolutely, yeah, I understand. Obviously, we've got a good couple of hundred men kind of listening to you here, Mike, and your advice and your information. What tips, what advice would you give to you know, a bloke who's worried about or is already struggling with incontinence? What are the kind of top things that you would want them to take away from this?
I think you've got to take the Boy Scouts attitude, be prepared. I always carried a man bag. It didn't look like a man bag necessarily, it was more like a computer bag, but I felt that was really important, where I had spare pads with me. I had nappy bags, for want of a better word, and I think that is really important. A radar key, which I thought radar keys were only for, you know, wheelchair people. And also I got a card through Prostate Cancer UK to say, help, I need your loo, can I use it quickly, which I think is very important, because not all disabilities are visible. I would advise anybody that is going out and about to, the first thing, it's a bit like coming out your house, of a brush my hair, or is my fly done up, etc., etc. I look round and look for where is my nearest public loo? How far am I away from a loo? If I'm in a pub, if the loo's upstairs, can I make it in time, or am I going to have to rely on using the disabled loo? Over the years, I've yet to be challenged by anybody for using a disabled loo. I have often said to people as I come out of it, by the way, I'm not abusing this. Oh, don't worry. No, don't worry. You know, I've got problems. But be prepared. I think that's really important. For those of you who are going through a difficult stage, and at my worst, I was using 15, 16 pads a day. And this was because of damage that suddenly clicked in. I think it's really important that you always carry sufficient product. And if you do get into a problem, I remember one instance, I was at the Classic Car Show at the NEC, and I thought I had enough I was carrying a backpack and enough pads to see me through. I ran out, I was going to sit in somebody's car for a 3-hour journey, and I had nothing left. I didn't even know at that point, when I was peeing, I had no control, it would just happen. So I went to one of the little shops in the NEC, and I just sort of braced up and went, I need one of those, pack of those, please. And as I was decanting them, I discovered that actually I'd gone and bought some ladies' tampons, which was not very clever. So I immediately went back, And the person said, I did wonder why you wanted them, but no, I understand. You've got an issue. This is what you need. Everybody, I think it's just one of these conversations men are frightened to talk about. Ladies do talk about it. I even bought a pack of Always, and I thought, well, this is good, because at the time the Always people on the advert made you skip, and I thought, well, that might increase my my sort of body language. So yeah, it's very, very important. You go to the professionals, you get help, and there is plenty of help out there.
Thank you, Mike. That's absolutely fantastic advice, and it's just it's wonderful to hear. Well, the good humor with which you deal with it all, but also just how affirming it is that when you make that step and you open up, even if it's somebody really close to you, or even if it's just somebody who you need to buy something from or needs to make a little allowance for you, that you've been met with with understanding and warmth generally. So thank you so much for sharing. Is there any final words, final thoughts from you, Mike, before we move on?
Well, yeah, I think you need to know that because my incontinence was so bad, I've subsequently, in 2019, I've had an artificial sphincter valve fitted, which has been totally life-changing. I'm down to 1 pad a day, and generally that's just for my own peace of mind. It's really good. And for those of you who, when you are incontinent, you get no feelings that you want a wee, that was one of my biggest things. Well, how do I know that I want a wee? And within a month, all those feelings came back. So I know I want a wee. I press the valve button, which is inside my scrotum, and I wee normally. And I've got pretty well a normal life. I think it's very important, and I don't want to tread on the medical team's toes here, but if you are about to have your operation or you're about to go through radiotherapy, please start doing your Pilates now. I felt that I left it a bit too late. The pelvic floor muscles are really important, and for want of a better word, I was told, just feel like you're pulling your nuts to your guts. Squeeze. There is also a Squeezy Man app, which disciplines you to remind you, and that was set up by one of the professionals at my hospital. I believe there might be a cost to that now. I think it's a minimal cost, but it's an app you can get on your phone. I would also like to say, never worry about your dignity when you're talking to these professionals. They've seen it all before. They're used to it. They're trained. Many of them will have had friends, partners, whoever, who have been through it. So please, you can use Prostate UK, who've been extremely helpful to me. Maggie's extremely good. The hospital. And finally, just as I would like to say, if you are going to buy pads and you get in a bit of a mess, for heaven's sake, make sure that the pad is placed correctly, because I have had myself putting one upside down, and that was pretty painful. So yeah, just remember, if you're in a mess, just do whatever, take your time. And if all these treatments do cause you these inconveniences with incontinence, just remember the treatments have probably saved your life. And in my case, they have. So anybody that says, would you still go through the treatments that were put forward for me? My answer would be yes, because the incontinence is not, it's been annoying, it's been stressful, but at the end of the day, 11 years on, I'm here.
Thank you so much, Mike. Thanks so much for sharing. It's really, really wonderful to hear that account, and thank you for speaking so honestly. Hopefully we'll be able to come back to you a bit later on. I'm just going to add on the Q&A. If people have questions for Mike, please do send those over, and we can involve Mike in the Q&A session later. Fantastic. So now we're going to move on and hear from our next panelist, Gerard Green. Gerard is a physiotherapist who specializes in male pelvic health, as well as the treatment of urinary incontinence and erectile dysfunction after prostate cancer treatment. And Gerard is going to talk about the management of urinary incontinence. Over to you, Gerard.
Thank you very much. My name is Gerard. I live in Birmingham, where I'm here today, and work both in Birmingham and London. And I'm quite fortunate in that I work with 3 other very skilled male pelvic health physios. And between us all, we see lots of men pre and post prostate cancer treatment. And we get to know those men very well. And we always kind of ask them, well, especially when we see them post-surgery, which initially tends to be for urinary incontinence, we ask them, well, what did you think it would be like after surgery? And a lot of them will say, well, I didn't think it would be like this. You know, I didn't really know what it would be like to have to use maybe 4-6 pads a day, to be wet at night. And I think, as Mike has said, it's what comes across from those men initially post-surgery is it's very distressing. It can be confusing what is best to do for the incontinence. And it has a massive impact on what people can do socially, going out for meals, getting back to work, getting back to maybe retirement activities. I've been quite fortunate that apart from working in the clinics, I'm also involved in kind of helping to train up other physiotherapists, both here in the UK, Ireland, where I'm from, and various places abroad prior to COVID. And I also do a lot of work locally, particularly in the West Midlands. We've got the Solihull Prostate Cancer UK group. And no matter where you go, whether it's, I was in Liverpool doing some training with some physios this weekend around prostate cancer complications. No matter where you go, what generally comes across is it can be difficult for these men post-prostate cancer to get help for urinary incontinence or erectile dysfunction. But I think the other thing that comes across is how unique Prostate Cancer UK support groups are. They are a very unique, supportive organisation, and what we strongly encourage all of the men we see to kind of go to their local group, whether that's patients we see in the Birmingham clinic, whether we see them online, whether we see them in London. And 2 patients really come to mind that I saw myself recently. Several weeks ago, saw a really nice Sikh gentleman, retired gentleman, and he came to the appointment with his daughter, who was in her pretty early 30s, and he was just having a difficult time. You know, his daughter said he just wasn't himself. He'd stopped meeting his friends. He'd stopped going out. He got quite kind of withdrawn. And I said to her, I said, well, you know, and I said to both of them, I said, what will really help you is to go to the group. He went to the group and got a huge amount of it, was able to meet some other men who kind of were going through similar things. And another patient was a really nice Afro-Caribbean man that I saw in the clinic in London. This was a big, strong man, and he would be quite emotional in clinic, a little bit tearful, in that he couldn't understand how he, big, strong, 6'3" man, was just leveled by this incontinence. And same again, he found his local group, which I think was in Tommy's in London, and transformational. So I think what really stands out is how amazing those support groups are. What we try and do is, when we see any of these men, either pre-surgery or post-prostatectomy, rather than seeing them as a pelvic floor, or as a pelvic floor patient, we find out what they do. So we say to them, well, before you were diagnosed, what did you do? And some of them will have been working, maybe in a manual job. We get people who work in construction. Someone might be a plumber. They might be they're retired, looking after their small grandchildren. They might be a runner. They might play golf. They might like traveling. They're a husband, partner. So we try and find out what they did before all this happened and what they want to get back to doing. And we try and then customize their pelvic floor rehab to that patient. So rather than giving everyone the same thing to do and keeping everyone doing the same thing, we customize it. So the person who's going back, maybe playing golf or squash or running, they will have to do a lot more things than someone maybe who's a little bit more sedentary. And I explain that as if someone had a knee replacement. If someone had a knee replacement and they want to get back to hill walking and hiking, they're probably going to have to do a little bit more than someone who has a knee replacement and isn't very active. A bit like Heather has said, the internal sphincter is really important for us as men for our urinary continence. That undergoes a lot of trauma during that surgery. So we're then dependent on this outer sphincter. And as Heather has said, that outer sphincter that wraps around the urethra is part of the pelvic floor, but it's part of the front pelvic floor, the anterior pelvic floor. And in men, you can kind of, at a very basic level, split this pelvic floor into a part at the back, which wraps around the rectum. That's kind of where you want to squeeze and stop yourself passing wind. And the part at the front, which wraps around the urethra or wee pipe. What's really important in terms of urinary control post-prostatectomy is that front pelvic floor. And this is a lot of patients we see, they'll be really trying to work that pelvic floor, but you ask them, well, what are you doing? If you had to teach me what you're doing, what would you tell? And they would say, well, I'm doing the obvious thing. I'm tightening around the rectum. And that's problematic because that doesn't really target that smaller front pelvic floor. We try and kind of move people away from doing that, squeezing around the rectum, squeezing around the back passage, and we shift people to the front in a way that Mike has said, where we get people to do this front contraction, which is doing this nuts to guts, this kind of visualizing that someone is stopping midstream and someone is lifting the scrotum up, and that's that nuts to guts. So one of the key things we do is just really shift focus from that tightening around the anus to doing these front contractions. I don't think this photo will ever date unless something dramatic happens in Paris. All skeletal muscles, a bit like our calf muscles, they've got fast twitch fibers, which allow us to run very fast, but for a very short duration. So that in the calf, that will allow us to sprint. The slow twitch fibers will allow us to stand, walk for a long period of time. And the pelvic floor is the same. The pelvic floor has got fast twitch fibers, which work at a very maximum high intensity, short duration. So those fast twitch fibers work when you cough, sneeze, you get up from sit to stand, you move suddenly, you lift something quite quickly. So we get people to do very fast contractions. Those are the fast contractions where you do the quick nuts to guts to the front, let go. Quick, let go. And when they're not working that well, or really these muscles they have to work a bit harder to compensate, a bit like Heather has said, for what's happened further up. Prostate's been removed, the internal valve or sphincter has been damaged. We also have slow twitch muscle fibers. Probably about 60–70% of the pelvic floor is slow twitch. So we get people to do these really slower contractions. So we get them to do the nuts to guts, that squeezing at the front. But rather than them doing it maximally 100%, you get them to do it at about 50–60%. So it's a lighter contraction. They keep breathing, try and get the contraction more so at the front. And you get them initially to hold for 10 seconds, do 10 repetitions. Then they can hold for 15–20 seconds. So we try and get people to do two things. And like Mike said, we want to do the nuts to gut, the front contraction, but we want to do some fast contractions and some slow contractions. And the squeezy app that Mike mentioned is brilliant for that. So squeezy app men that my brilliant friend and colleague Myra Robson developed. She's a really amazing pelvic health physio. People like to know, well, how is my pelvic floor getting better? So what we can do this time test. We can see, well, how long does it take someone to do 10 good quality fast front contractions? And normally, if everything is going well, they should come in at about 1 per second. So on average, it will take someone about 10 to 15 seconds to do 10 fast contractions. And then we do this slow hold where we see, well, how long can someone hold a slow lighter contraction? And that on average comes in maybe about 50 seconds or so. That will vary a little. People also want to know, well, am I doing them correctly? Because I think, you know, most men prior to treatment for prostate cancer, pelvic floor is not usually on their horizon unless maybe they've been through maybe treatment for a bowel condition. But generally, we can move through life not really engaging with that pelvic floor as men. People want to know, well, am I doing them correctly? But there can be a bit of concern here because people think, well, I'm going to see a pelvic health physio, so well, they're probably going to have to examine me internally, but I've had a lot of that done before the surgery. Maybe I'm not sure I want any more done. And if they have to examine me internally, well, then I'll have to take my underwear and pad off and I might leak, and that's distressing. Now, the good news is we're not interested in what's happening in the rectum. We're not interested in that anal sphincter, so we don't do any internal examination on these patients. What we do, which is much easier, less invasive, is we stick an ultrasound probe, which is like a probe someone would use maybe to have an abdominal scan, maybe a bladder scan before the surgery. So we put that probe in the lower tummy. That allows us to see the bladder. And if you contract the pelvic floor, the base of the bladder will lift. So that gives us an external or outer way of saying you're doing it correctly or you're not doing it correctly. With some patients, we might do a transperineal scan. So that's where you put the ultrasound probe on the perineum, the soft part underneath. But that's unusual. With the majority of patients, it's transabdominal, lower abdomen, lower tummy. And we also want people to train these muscles, a bit like Mike said he's done. We want them to do them in standing. So we want them to do the nuts to guts, the fast contractions, the slow, but we want them to do them in standing. And this is another thing that we commonly see, which is no one's fault, is that someone might come in and they're maybe 3-4 months after surgery, and they're doing pelvic floor exercises, but they're maybe doing the rectal contractions, or maybe they're doing the nuts to guts, which is good. And you say to them, well, what position are you doing them in? And lots of them will say, well, I'm doing them in sitting, or I'm doing them in lying, because that's what I was shown, or that's what was on the sheet. And the problem with that is if someone's in lying, generally they're dry. If they're in sitting, they're generally dry. Where the incontinence comes on is on movement, sit to stand, bending, lots of activity, cough, sneeze. So we get them to really start to do these in standing, and a good starting position is almost standing, one knee slightly bent. So it's almost like supported standing. And then people want to know, well, how many times a day should I do them? And a bit like I said to a new patient last week who attended with his wife. And I said, it's better to do them properly once a day. And then once you feel you're doing 10 fast, 10 slow, once you feel you're doing that well, then do them twice a day. And once you're doing them twice a day, maximum 3 times a day. You don't want to be doing these all the time, because if you do them all the time, you can start to get a little bit of discomfort, a little bit of pain, but like Heather mentioned, that kind of cystitis type pain. But you can also fatigue the muscles, so it makes the incontinence a bit worse. Another thing that we see lots of men who want to get back doing lots of things, lots of activity. So someone might come in and they will go, so I play golf, not particularly well. I have like us all, I have my moments where I think I could be good, but it lasts about 3 holes. Someone will come in and they go, well, I'm dry most of the time, but when I play golf, I'm leaking. Or when I've tried to get back running, but I'm really struggling. And with those men, they just need to do more than just contracting that pelvic floor and standing. So we get them to do things like pelvic floor work with squatting, with lunging, with resistance bands. So we just load that pelvic floor. We just get it working harder. A bit like if those people had some knee or hip surgery, they would be doing probably a lot more progressive rehab, progressive strengthening. So this is coming back to the point. We don't see everyone as the same. We work out, well, what does this person want to get back doing? And the knack is really where you work out, particularly in the first weeks, months post-surgery. Lots of people will say, well, once I go from sit to stand, once I stand, come out of a chair, I'm leaking. So you get them to do that quite strong pelvic floor contraction in advance of the standing, or it might be that when they bend down to do their shoes. So you get them to do contraction, activity where they're leaking. And what that tends to do over a couple of weeks, you get that timing improves. So then they will find, actually, I don't need to do that anymore. You know, when I get up in the morning or dry myself after the shower, I'm not getting that leaking, because the knack helps this timing. Timing before surgery, when that internal sphincter that Heather spoke about, when that's working, the prostate is there, that pelvic floor doesn't have to do too much in men. But post-surgery, it needs to work harder, and its timing has to improve. We also get people to wean off the pads. As people are getting drier, we get them to do this pad weaning. And as Heather said, the initial sign of improvement is people getting dry overnight. And then people start to be a bit drier early in the morning. So it can, when people's confidence is improving, it can still be difficult to take that pad out at night. So we kind of said, well, you know, you've been dry at night for a couple of weeks now, so let's move from a pad to maybe a shield. And then once that's dry, just wear just what you normally would in bed. And psychologically, that's a big movement forwards. And then as people get drier, we get them to reduce the pad size, put a pad in later in the morning, and then say in the evening, if they're not doing too much, leave the pad out then. Another problem that Heather mentioned is where people can get maybe frequency and urgency. What we do here is a little bit of bladder retraining, looking at, well, what fluids are people taking in, what's their kind of bladder pattern, their voiding pattern like. So we do some bladder retraining with them. And another way of the bladder retraining is important because lots of men will, if people have got incontinence or frequency urgency, it can be intuitive to reduce the volume of intake, to really cut down on what fluids they're drinking. So that needs to be gradually increased, emphasis on gradually, to increase the bladder holding capacity. So that bladder gets used to holding more. So the bladder gets used to that, becomes normal again. And also that pelvic floor, which is underneath the bladder, gets used to that weight. And we also do lots of bowel stuff. But like Mike mentioned, that people can get bowel symptoms as well. And bowel, things like constipation, has a big impact on pelvic floor function, has a big impact on urinary symptoms. So although people are coming with maybe urinary incontinence or erectile dysfunction, we ask them lots of bowel stuff too, because that bowel needs to be in a happy place. Otherwise, it can drive some of those urinary symptoms. I like all of these things. My dad was a doctor. In Ireland, we grew up, I like dairy stuff. I'm fond of a tipple. I love chocolate and I love coffee and I love Indian food. So I'm kind of a realist here. What we get people to do is just to modify. Sometimes it's unrealistic to say you can't drink any coffee or you can't drink any alcohol. We get people to modify. We work out what is the pattern. Do they need to modify some of this? This is really around maybe nighttime voiding, frequency urgency. So we don't ban things. We kind of ask people to, we see, well, is it relevant? And then we kind of maybe get people to do a bladder diary, and then we get people to modify a little bit. AC cuff is something that is useful for someone whose maybe continence is problematic still, or the person whose continence is good, but they need a little bit of help for some events where there's concern over leakage. That might be someone doing a presentation, more that live presentation, or someone's going to a function or a wedding. So the pacey cuff is something that you could discuss with your either urology nurse specialist or your pelvic health physio to see if that's something that you may benefit from. And that's produced by the company that produced the vacuum pumps, the Soma Erect pump. So it's the same company. So they're very well produced. Just lastly, another problem that some men can have is that, and I always think this is a tough one, because someone has worked hard, they've got their continence back, their continence is very good, their urinary control is very good. They've worked hard with the medication, maybe the tadalafil, the vacuum pump, and the vacuum pumps are not easy to use. It needs a lot of dedication. Vacuum pump needs a lot of kind of dedication to that. So someone's worked hard with the continence, the erectile function, but now they're back either enjoying self-intimacy or intimacy with a partner, and they're getting some leaking on sexual activity, leaking on arousal or leaking on orgasm. And that's a distressing thing, particularly with a partner. So usually what helps with that climacturia or that kind of arousal leakage is doing lots and lots and lots of those fast contractions, because that's really a sphincter problem, a fast twitch sphincter problem. I always think with the climacturia, it's almost that these men that we get to know really, really well, we get to know them well, that, they've done so well to get to the point of good function, good urinary, good erectile, and then someone decides, let's just give them something else to worry about. So climacturia is not too common, but probably 5–10%, but it's distressing if someone has it. And then once the continence is fine, people want to progress to finding out, what can I do to improve my erectile function? But usually when the people we see in clinic, they want to get their continence improved. Once their continence improved, then they want to know, what can I do for my erectile function? And when you speak to the men, and I've spoken to a lot of men, usually the follow-up care on erectile function tends to not even be as good as that of the continence. And just finally, these are some brilliant books to read. These are Prostate Recovery Map is written by Craig, who's a physio colleague in Australia. Facing the Tiger is written by Suzanne Chambers, who's a clinical psychologist working in prostate cancer for Prostate Cancer Australia. And Conquering Incontinence was written by Peter Dornan, who's an amazing man. He's a physio, an award-winning sculptor. He's a prostate cancer survivor, and that's Conquering Incontinence. And people read these and they go, actually, they're describing me. So these are really good things to read. And a bit like Mike said, just to finish, there is really good evidence that if people do the pelvic floor work pre-operatively, they get better outcomes in terms of continence. And the ideal time seems to be about for a minimum of 6 weeks. It's also much easier to do this prior to surgery when people aren't leaking, aren't wearing pads, haven't been through surgery to that area. So the men we see pre-surgery, they're much easier to work with because you can get them doing all this prior to the surgery. And then they also know what's normal to expect. And if people know what's normal to expect, it tends to be less stressing. And then finally, Milius is the woman who came up with the nuts to guts work. She is kind of single-handedly trying to mobilize the physio professions in many countries to do more, to get involved in prostate cancer. Jo is based in Australia, and on her podcast with Melissa, there is some fantastic stuff. And I'd like to say a big thank you to Prostate Cancer UK for the invitation to speak, and I hope people have enjoyed the talk. And thank you very much.
Thank you so much, Gerard. That was absolutely fantastic. A real, yeah, you've managed to pack so much in there. Really informative stuff, and hopefully a huge amount there that men can take away and really help them to kind of take control of their situation. So thank you so much. And again, there's already been some great questions coming in the Q&A, so I'm sure we'll hear more from you in a few moments' time. But before we get to the Q&A, we are just going to come back to Heather for a few moments. Heather is going to talk a little more about what we're doing at Prostate Cancer UK to support men with prostate cancer who are experiencing incontinence.
Thanks so much, Nick. That's brilliant. And thanks so much, Gerard. That was a brilliant talk. And I know you came to speak to us a couple of years back at the charity to the nurses, and we took so much from your talk. And I bought the book, Craig's book, and it was fantastic. It really is a great read. So just on this slide here is some information about what us at Prostate Cancer UK are doing to try and help. So you can see, first of all, is our picture of our surgery support pack. So we know from speaking to men that trying to navigate incontinence and incontinence products, you know, just as Mike was saying earlier, can be very daunting. And our surgery support packs are a one-off pack, including a fact sheet on surgery and pelvic floor exercises, as well as wet wipes and disposable bags. And the pack can help prepare men for surgery and post-op continence issues. And it's a guide about products that are available that they might want to purchase. We generally send out about over 4,000 packs per year. On my slide as well, I just mentioned the nurse helpline, and we've talked about it throughout this webinar, but we have email, the phone, live chat and WhatsApp services, which is a safe space to talk about incontinence issues. You know, we know how important it is to talk about these things, but also, you know, we can hopefully guide you in situations and maybe tell you where to go. That is the next step to get help. So please feel free to reach out to us where we can hopefully help with discussing management strategies. We also signpost to useful organisations, places like Bladder and Bowel UK, or sometimes the continenceproductadvisor.org and many other places. So just as you see on my slide, I have written boys need bins. So this was talked about earlier, and this is something that I just want to touch on a little bit more. So we know that men talk about, as Mike did, that the anxiety and the challenges they face when they're out in public and need to dispose of their incontinence pads. So we know it shouldn't be this way, and that's what led us to the Boys Need Bins campaign. And the campaign has helped generate more than 2,500 letters to MPs calling on them to take action to improve the quality and provision of male sanitary bins. And 18 councils nationally have now drafted or passed motions to have sanitary bins in their areas. As a charity, we want every public toilet and business across the UK to put incontinent bins in their male toilets so that men can dispose of their incontinence pads, their stoma products and other hygiene waste items safely and with dignity, just as Mike talked about. And we're continuing to work with our partners, PHS Group, which I'll go on to talk about now, and lobbying the government for change as well. So in my last little picture in my slide, I've mentioned partnerships. So we've teamed up with long-term partner Tenna Men. So Tenna manufacture pads and pants for men who experience urinary leakage. They promote our health messages across many major retailers, and they have generously donated, proceeds from every pack sold at key moments of the year, as well as donating many pads for us to then use in our surgical support packs. And we've also, as a charity, we've joined forces with the UK's largest hygiene service provider, PHS Group. And that was to create the Dispose with Dignity campaign. And that campaign is tackling the taboo around male continence and pushing again for the government to legislate for the provision of incontinence bins in male toilets. So as part of that campaign, we worked with PHS Group to create a new male incontinence bin, which businesses across the country will be stocking to create a better world for men dealing with incontinence. This will hopefully, as I say again, allow men to dispose of their pads and associated products safely and hygienically with dignity. And that is what we hope for as a charity.
Fantastic. Thank you so much, Heather. Yeah, really good to see all of that activity that's gone on. Not just from a kind of information and support perspective, but more broadly in terms of driving change. So now we're going to make a start on our Q&A, and a big thank you to all of those of you who've submitted questions already through the talks. There's been plenty, so I can see that we've already had 26 answered in the chat by Vicky and Grace, so absolutely heroic effort there. Thank you so much. So as a reminder, we obviously have our panelists here who will be able to answer some of your questions, and Grace and Vicky are still on hand to respond to some more in the chat. If you've still got a question you wanted to ask, please do so. Remember, don't include detailed personal health information in the question. We won't be able to answer it, and we can't give advice on any individual cases. And just remember that only the questions that we answer in the chat will be visible on Zoom. And for those of you who don't get your question answered, I will just give a reminder of the specialist nurse contact details a little bit later on. So let me have a look at what's coming. I'm really glad that we've got a question that's coming from Mike, actually, from the lived experience angle. So Mike, there's a really interesting question that's coming here around work. So if you don't mind sharing, what were you doing for work, and how did you kind of get back into the groove work-wise after your treatment with the incontinence?
Sadly, I didn't return to work, and that was because I ended up having a nervous breakdown about the whole thing, and I took a redundancy package. But my initial plans were that I would be going back to work within 6-8 weeks, because my previous job, my job had been traveling around the UK as a sales manager. I could be in a car for 6 hours, with stops and things. So it wasn't really practical. So unfortunately, I was forced into very early retirement.
Well, thank you. Thanks for sharing that, Mike, and for being honest. And yeah, clearly there were some very specific aspects to your job there that meant that wasn't available. Yeah, we have some information on our website more generally about returning to work. So whoever has asked that question, that would be potentially a good place to start. Thank you, Mike. Thanks for sharing. Right, so I've got a question around radiotherapy and surgery. So I think this is probably one for Gerard. So one says, I've been told by a urologist that having had radiotherapy a few years after a radical prostatectomy, then pelvic floor exercises are not effective. So Gerard, just wondering if you could jump in on that one.
Yeah, so I think it probably is dependent on the symptoms. So if the symptoms are frequency, urgency, then that tends to respond more to bladder retraining. If it's a symptom of pelvic pain, so pelvic pain is where there's maybe pain on urination, pain on bowel movements, maybe pain in that perineum rectal area. So that tends to be a condition of overactivity of the muscles, where the muscles are almost a little bit, have become sensitized, painful, overactive. So pelvic floor exercises tend to aggravate that. So that patient tends to do more pelvic floor relaxation. But if it's a problem of maybe anal sphincter weakness, which is maybe fecal leakage, maybe difficulty controlling wind, so there is a role for pelvic floor exercises there, more so based around that kind of contracting the anus. Whereas if it's urinary incontinence, there is a role for those, as Mike said, that kind of front nuts to guts. And I think also the urologists are incredibly specialized and brilliant at what they do, but sometimes the urinary symptoms, whether it's post-radiation, post-prostatectomy, whether it's the bowel symptoms, is possibly less of a priority for them. So sometimes what can then be helpful is to find someone who's maybe a pelvic health specialist, or sometimes it's good to speak to the urology nurse specialist, because they sometimes are possibly more used to dealing with those post-treatment complications, a bit like Heather has also talked about.
Yeah, thanks, Jared. And I think this next one probably follows on from that quite nicely, which is, my incontinence was reasonably well managed for 10 years, but now is getting worse. And would bespoke physio in that situation, is that likely to help someone improve at that stage? And would they ever get it to kind of back as good as it?
Yeah, so and that's a common thing we see, and it's this kind of comes back to that kind of detailed assessment, trying to work out, well, what has changed? So obviously the continence has changed. It's got worse, but what else has changed? So the things that we know that can affect continence is things like someone's maybe had other medical conditions, respiratory conditions, kind of chest infections, and maybe someone's got maybe a bit less active, maybe they've had a knee hip replacement, someone's maybe had an associated bowel condition, maybe they've developed things like constipation, they've developed some abdominal. So I think what we try and work out is there's always a reason. What is the reason for it? Are there associated things that are contributing to that deterioration? See if we can address those. But generally, if someone's continence was very good, usually their prognosis on getting them back to near that point is generally quite good, with working out what's caused that deterioration and then getting them back on track with some of that pelvic floor work, maybe addressing some of that bowel stuff, that digestion stuff, general activity. And sometimes the pelvic floor is one part, a bit like Mike said, he does Pilates. The pelvic floor is one part of it. It's trying to work out what else is going on.
Great, thank you. This next one's probably for you as well, actually, Gerard. You're a man in demand. So we've had quite a few questions just around Botox to the bladder. I wonder if you can give any insight into that.
Yeah, so that's not something that I've come across very much, really. Where I've come across, but it's for a very different condition, is in terms of treatment for pelvic pain and urinary pain. But it's not something that I have seen in terms of treating that urinary incontinence. Is that something you've come across, Heather?
Yeah, we talk to people who maybe be referred for bladder Botox, but not very often, because it's not, as you say, Jared, it's not really linked to their prostate cancer. A lot of the time it would be more to do with maybe potentially damage from radiation to the bladder, possibly, and maybe a urologist is looking for something that might help. In that instance, they might talk about medication. They might talk about the Betmigas or different types of medications that can be used to help with bladder spasm. And then sometimes they might say, well, we're going to refer you on to look at bladder Botox. But as far as I'm aware, there isn't a huge amount of evidence point to Botox being useful in the prostate world, more like possibly a bit of a trial to see whether maybe this may help, rather than there been something very concrete on it.
That's fantastic. Thank you. Thank you both. Right. I'm going to see if I can just pull one more out of the hat here. Right, bear with me. Again, this is probably another one that Gerard and Heather, you can both take between you. I think it's probably a nice one to sum it up. Are pelvic floor exercises for life as opposed to just for Christmas, I assume? And is it expected that more help will be needed as I get older?
Okay, so I think the answer to that is it depends. What you try and get people to do is to incorporate some of that pelvic floor work into the other activities they're back doing. So there will be some men who want to go back to the gym. There will be men who want to go back to Pilates. There will be men who want to go back to yoga. So you get them to incorporate that. They will be doing a higher level of pelvic floor work incorporated into that normal exercise. For those other men, if their continence has returned and is fine, you usually get them to taper it off. Because if it's not a problem, it's no longer a problem. So then people will just generally reduce doing them anyways. For the people where there are some patients where they've got maybe a low level of incontinence, where they will have to maybe continue doing them. So I think the answer to that is it kind of depends on that individual situation. Sometimes you find people have stopped them, they've been very good, their continence is at a good level, and something else happens. They get COVID. They develop, they've been on holidays and they get a vomiting bug. They have another medical problem, their continence deteriorates. So then they kind of get back on board with doing it.
Fantastic. Thanks, Gerard. Heather, anything you would add to that one?
I think exactly as Jared said, and from we talk to men all the time on the phone who are either have kind of asking us that same question, whether they should continue it. And it is just that it is going to be so individual to the person as to how they're going to schedule that going forward. Because, truthfully, you have to be realistic, as Jared was even saying, when you look at, for example, the bladder irritants, we have to be realistic and say, well, you can't cut everything out. And we have to be realistic when we think about going forward with pelvic floor exercises as well. Realistically, is a man going to continue that same level throughout the rest of their life? And probably not. So it's more about trying to maintain, like Jared just said, what is needed for that person. So I don't know if there's an exact answer, but I would just be kind of in agreement very much with what Jared said from people we speak to.
Thanks, Heather. I'm going to squeeze in one more before we call an end to it. So this one probably for you, at least initially, Heather. So this one says, I had a radical prostatectomy 5 years ago. I can't get more than 4 hours continuous sleep without waking for a wee. I don't drink after 6 p.m. I don't leak. I go to bed at 1 a.m. Any thoughts?
And so difficult, especially after 5 years after your treatment. You think you're out of the woods, of course. I think firstly, the not drinking after 6 p.m. is something that we would recommend, or generally 4 hours usually before you go to bed. If you're having this kind of trouble, that would be something we would suggest. Obviously, avoiding the irritants as much as you can. Again, what Jared mentioned earlier. And I think maybe, Jared, you could come in on this, but there probably is a bit of an element of bladder retraining needed in this case. This is not necessarily, this is potentially something like maybe that we could kind of extend the volume that the bladder could hold, which could help a lot in this situation, not necessarily the valve or the sphincter, but the volume. I don't know if you'd agree there, Jared, with that.
Yeah, so that sounds like that very typical symptom of bladder overactivity, reduced holding volume. So sometimes what you would, bit like Heather said, what you would probably look at there is more bladder retraining rather than a pelvic floor type program. And sometimes what helps there is doing like a bladder diary for even about a week to really work out. So there's an obvious pattern at night, because that's what you've mentioned, that you're waking, but to see what is the pattern during the day in terms of volume in and voiding and amount voided. So sometimes although the symptoms are at night, and that's the distressing thing, waking every night to void, is you work out what is the 24-hour pattern like, and sometimes you start to address the daytime pattern in terms of fluid in, voiding, frequency of voiding, and sometimes by changing that daytime pattern, you start to get changes at night. But it's a difficult one. But that sounds like an overactive bladder type presentation, as opposed to an external or internal sphincter problem.
Perfect. Thank you so much, both. Unfortunately, that is pretty much almost all we've got time for this evening, although we're just going to end with one more bit of interactivity. We're going to end with another poll. So you should see this come up. So this is just a very kind of snap, how did you find the webinar today? We'll follow up with a more formal evaluation questionnaire that we'll send out, where you can go into a bit more detail and provide a bit more narrative. But yeah, we just wanted to get a quick kind of snap response to this, and it looks like by and large people really found it useful, which is fantastic to see. I'll leave that up there for a little bit just so the rest of the results can come in. But I wanted to say a huge thank you to our panel, Heather, Gerard, and especially Mike, for sharing his story and for offering so much wisdom and insight into his situation. I know it will be really greatly appreciated by those experiencing incontinence or waiting for treatment. We just close the poll down there. So please keep an eye on your email inbox over the next few days. We'll share a survey to ask you how you found this webinar, as I said, in a bit more detail, and your thoughts are vital in helping us to shape our information and support. So please take the time to do that if you can. We also will be sharing a recording of this webinar over email. Don't forget, there's a wealth of prostate cancer information on our website, and our specialist nurses are available Monday to Friday, 9 till 5 on 0800 074 8383. And keep your eyes peeled for more webinars as well. The next one in the pipeline is around physical activity and prostate cancer, coming in the next few months. But that's it for now. Thanks again to our panel, and have a good evening, everyone, and take care. Goodbye.
Thank you.
Thank you.